Good afternoon to everyone present here with us today. This is Shreyan from IJCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Ash Sujit G. Sir is MBBS Diplomat of National Board in Obs and Gynecology, Fellowship in Minimal Access Surgery. Sir also have Diploma in Gynecology Endoscopy. Sir is a Senior Consultant in Gynecology and Obs Department at PD Hinduja Hospital, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is premenopause and its challenges. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Good afternoon, everyone. Thank you, Sharon. Good afternoon, everyone who is coming here. Just give me a second to start on with the topic for today. So, today we'll be talking about perimenopause and how we can overcome the challenges as doctors. To understand this, I always like to use a quote which was given by Dr. Jen Gunter, which she said that there is no greater act of feminism than speaking up about menopausal body in a patriarchal society. So let's begin with what is menopause. So menos is in Greek, which means month, and pause means to stop. So as we can see that if there is any stoppage of the monthly cycle for a period of 1 year or longer, that is our technical definition, what we use as menopause. When we look into the various statistics, in India, the average age of menopause is roughly at around 46.2, whereas in the West, it can vary between 51 to 52. This forms an important juncture in the life of any woman because there are a lot of changes that happens from being in a reproductive age which has lasted for maybe around 30, 35 years till suddenly reaching a phase where there is no longer any bleeding that happens. And this, as we know, that it happens because of loss of ovarian function. And the journey itself is very gradual, which can happen for a longer period before the menopause, and it might last even after menopause. And that is what we refer to as perimenopause. So you have a circle, anything going around it is peri, so that's perimenopause for you. With menopause in the center, it can start even before, maybe around 5 to 10 years before menopause. And it usually is seen that it lasts even maybe around 2 to 5 years after menopause also. The way you can find out whether a woman is perimenopausal is by asking a proper detailed history. This can last several years and it can lead to a lot of changes, which can be emotional, physical, mental, and a social well-being can be affected. And therefore, you need to understand this period. So you have to understand that there's something a woman will be going through over the next at least 10 years of her life. So it's just not like maybe it's there for a cycle or maybe just for a month or so or a year. It might be even for 10 years. So you need to address this issue. And once you know that there are certain issues that are there, you can think about a variety of non-hormonal hormonal interventions that you can do so that the patient or the lady is better. So what is menopause? It's a transition time around menopause. And like I already said, it can last maybe around 10 years at least. And during this entire time, what happens is the egg release is usually less regular. This leads to imbalance in the hormonal levels of the lady, which is mainly the estrogen levels become a little more irregular. This can lead to less fertility and more irregular cycles. This is what is the pathology behind it. And there are a lot of challenges that we need to understand. Why we are talking about it? Because the perimenopausal woman needs to access to proper health services and community that can support them. But if as doctors or even if as patients, there is no awareness around this topic, then it becomes a significant challenge when you want to still talk about it. Menopause or perimenopause is still not discussed within families, communities, and workplaces also. And then you have someone who's going through the symptoms. How do you come up with a treatment if you're not talking about the symptoms and don't go to someone who can alleviate your pain or discomfort? Those experiencing menopausal symptoms may also feel embarrassed or ashamed to draw attention to their experiences and even not being very comfortable asking for support. The sexual well-being of menopausal, perimenopausal women is also underlooked in most of the countries. So much so that if a woman needs to address some things regarding vaginal dryness or dyspareunia, even she finds it difficult to speak up to her own gynecologist. Also, at this age, the vagina starts becoming dry, and since the woman thinks that now the chance of fertility decreases, she might land up with accidental pregnancies or she might be at a high risk of getting any STIs. Healthcare providers themselves, at one point, me or you or any other doctor, might not be trained to recognize perimenopausal and postmenopausal symptoms and counsel them regarding for the same. And itself, there's a lack of training, or we don't have much of discussion which happens, or even as we study in our books, we don't find a lot of topics which deal with such important patient aspects. So in general, many government also don't have a lot of health policies or any financing which are related to perimenopause or menopause related diagnosis. So a woman finds it difficult also to avail the services because they can be a little costly for them. So perimenopause is a natural process, and this happens when the ovaries stop functioning. The ovulation becomes erratic, and the menstrual period might be lengthier, and the flow might become irregular. Symptoms are caused by changing levels of hormones in the body. When the estrogen is higher, you might have symptoms that have higher perimenopausal symptoms. When the estrogen is lower, you might have something which includes hot flashes. And these hormone changes may be mixed even with normal cycles. So the culprit or the major thing that happens is because of estrogen irregularity. So to go for this irregularity, I'll just explain you something which we all know about, that every month you have a cycle that happens. It's because whenever a cycle starts to happen, the egg is recruited and the egg becomes the sole provider for estrogen and progesterone. As the egg grows, the estrogen levels start increasing. There's an ovulation that happens, and then if the egg doesn't, if there's a no fertility which happens, then the estrogen and the progesterone starts declining, and then you have your periods. This is something in general that is seen in a normal menstrual cycle. Now imagine the estrogen level doesn't reach that level, which has to lead to ovulation. So you'll have anovulatory cycles also. The estrogen level reaches there, but the balance is not maintained because of age-related egg effects or the other lifestyle changes that happen in. So the balance between estrogen and progesterone is also imbalanced. So the progesterone support is also not very proper. So all these things lead to irregular bleeding, some random spotting, or you have cycles which are very lengthier, or you might have scanty periods. So all these things might be a part and parcel of perimenopause. Other symptoms that you can come across are these. I usually like to point it from head to toe. When you go from head to toe, you might have hair fall issues. The patient might have hair fall issues. There might be drying of skin that can happen. There might be tingling of fingers, burning of feet, calf cramping, or random breast pain can happen. And there might be a lot of emotional changes and vasomotor changes, what we call as night sweats or hot flashes. The patient might suddenly wake up with sweating, might feel hot in a cold environment. There are changes with respect to moods where the patient will have a lot of anxiety, or patient might have shifting of mood where she's suddenly very angry or suddenly feel like crying. There's a forgetfulness pattern which starts happening in, and the patient also will have some trouble with sleeping. Along with that, the patient might complain of difficulty in intercourse or vaginal dryness or change in sexual desire also. All these things can happen, nothing also can happen, or few of these things can happen at different intensity. So what one needs to understand is that no two women will experience perimenopause in the same way. So now let's understand what happens with each of the symptoms and how you can manage them. So hot flashes and night sweats refer to sudden feeling of heat on the face, neck, and the chest, often accompanied by flushing of the skin, perspiration, palpitation, and acute feeling of physical discomfort, which can last even for several minutes. An estimated around 35 to 50% of perimenopausal women suffer sudden waves of body heat with sweating and flushing, that can last 5 to 10 minutes, often at night as well as during the day. This typically begins from the scalp area, moves down to the face, neck, and chest, and can differ dramatically from one woman to the other. Some might just feel a feeling of warmth, some might just end up getting sweaty so much that they all feel that there is a ringing wetness that has happened in. Hot flashes can often continue even for a year or two after menopause. In 10% women, it might even persist beyond that. The other thing that can happen is vaginal dryness. During late perimenopause, falling estrogen levels can lead to changes in the vaginal tissue, leading it to become thinner and drier. Vaginal dryness, which will be progressively increasing, can lead to itching and irritation also. It might also lead to dyspareunia, and that can also act as a reason why there is decreased drive for sex after the age of 40. Uterine bleeding, we've already discussed about this entire thing. There's an irregular balance which happens between estrogen and progesterone. The lining can become very thicker. Shedding of this lining can be very leading to very heavy periods with clots or with pain. Along with that, at this age, you might come across fibroids or endometriosis, which are because of more estrogen stimulation, and that itself can lead to heavy bleeding and painful cycles. Sleep disturbances, around 40% of perimenopausal women have sleep problems. Some studies show that there's a relationship between night sweats and disturbed sleep, and others show that there's no correlation for that. The problem is actually a complex one, which is most oftenly blamed on this hormonal oscillation. Sleep change itself can happen with age, and that is something which is common for both sexes also. Mood symptoms estimate that the number of women who experience mood changes at around 10 to 20%, and estrogen has been linked to depression during perimenopause menopause transition, but there's no proof that depression in women of midlife ages reflect that declining hormonal levels are the reason for it. In fact, women actually have a lower rate of depression after the age of 45 than before, according to studies. But the major reason why this happens is because there is a lack of acceptability which happens in the society. She undergoes a lot of emotional changes which can happen, and that can lead to more depression because of the fact that she is not being understood regarding her issues. Menopause-related hormone changes are also unlikely to make a woman more anxious or chronic irritability, although the predictability and the unpredictability of menopause can be stressful, and this can itself evoke episodes of irritability. Some women may be more vulnerable than the others because of hormone-related mood changes. In this, the best predictors of these are the stress which can happen at workplace or at family, poor overall health, and a history of depression in the past. Other problems that can include for a woman at this age might be they might be complaining of short-term memory problems and difficulty in concentrating during the menopausal transition. Although estrogen and progesterone are the players in maintaining brain function, there's little or too little information to separate the effects of aging and psychosociological factors that are related to hormone changes. Bladder and vaginal problems, when estrogen level starts reducing, the vagina loses its lubrication and elasticity, making it painful for intercourse. This we have already seen. Low estrogen level can also lead you more vulnerable to urinary and vaginal infections, and loss of tissue may contribute to urinary incontinence. So what happens is I always tell that if you imagine this three, if you can see the video now on the side, you have the bladder, you have the uterus, and you have the rectum. And in between, you have the pelvic floor. So what happens if there is a weakness that has happened because of vaginal delivery or because of constipation or because of any abdominal pass? During the reproductive age group, the estrogen takes care of this pelvic floor and this equity is maintained. But as you start aging, the estrogen levels start declining, the weakness starts happening. So this is what happens. There's a falling which happens in, and then what happens is becomes weaker. You might have complaints of prolapse. You might complain of this. So what happens when there's a prolapse or fall which happens in? Look at this finger, which is the bladder finger. This also starts weakening. There's a fall in the angle. There's a change in the angle. So you have a lot of Urinary complaints where the patients can complain of SUI, suddenly coughing, sneezing, laughing can lead to leaking of urine, or the patient can complain of inability to hold urine for a long time. There's a lot of residual urine that can happen because, again, the change in the angle that happens for the bladder, and the patient will have more risk of getting frequent UTIs. So all these things also need to be addressed when you're talking to a woman around perimenopause, menopause age group. Along with this, there is decreasing fertility that can happen since the ovulation becomes irregular. Chances of pregnancy also goes down. But it is important to understand the chances of pregnancy, even though going down, doesn't mean that the patient can be infertile totally. There are chances that she can still become pregnant. So it's always important to use some mode of contraception if one is having sex during the perimenopause age group. We see a lot of accidental pregnancies during this part. So a condom is always advisable if she is not on any other pill. Along with that, the condom will also reduce the risk of STIs because of vaginal dryness, which increases the probability of getting STIs. There's a loss of bone which is seen because estrogen is also responsible to make the bone stronger. So for anyone who knows or who has gone through the bone development, we have estrogen, the osteoclast and osteoblast. The osteoblastic activity is something which is estrogen related. So if the estrogen starts declining, the osteoblastic activity goes down. So your osteoclast takes over. So that is what leads to osteoporosis, which is something which is gradual, which starts from perimenopause and can move on and can become worse once menopause sets in. Also, the cholesterol level imbalance sets in because of change in metabolism, which is happening with menopause. So the LDL level starts increasing vis-a-vis the HDL level, which is a good cholesterol, which starts decreasing. And this is why women are at a more risk of getting heart-related issues once they hit the perimenopause, menopause age group. So how do you diagnose all these things? Diagnosis basically by taking a proper history. Anyone above 40, you should start an open-handed conversation where you talk about perimenopause. And once you start talking about it, the woman will also add to it saying that, yes, she's also facing certain issues which are happening. So then she'll start opening up more and you can identify certain symptoms. Get into the detail of a proper medical history and do a physical examination as and when required. Blood test usually tells me about the menopausal or the perimenopausal status. So you can do a day 2 or day 3 FSH and estrogen level. These are the two blood investigations which will tell me about when she is going to reach menopause or how perimenopausal she is. My reason for getting the blood test is always because if I have to do some surgery and if I think that it can be avoided, then I get this test done. If this tells me that yes, menopause is imminent and within the next couple of years the menopause will happen, then I try to wait on for a surgery and do a symptomatic management. But if the test tells me no, like menopause is going to take at least 5 years or more, and the patient is not comfortable doing a symptomatic management, then we can opt for a surgery. So this is where the blood levels of the hormones come into play. Also, diagnosis is important because you know when to control the risk and the issues which can happen with perimenopause, menopause, which includes the non-communicable diseases, the cancers, and the osteoporosis. So what's the treatment? So most of the times perimenopause do not need actual medical treatment, and a little holistic approach and lifestyle changes are itself sufficient. Hormone therapy forms the mainstay of treatment if you need to do anything which has to be dealing with these issues. Apart from that, moods might require certain psychological counseling and certain antidepressants which can be needed at times. Lifestyle changes, I would say, forms the mainstay of treatment or mainstay of management of certain issues which are related to perimenopause. In general, a proper balanced diet with proper meals are something which is advisable. Intermittent fasting, which is a fad these days, which is happening, will lead to a lot of can lead to a lot of changes in the diet and the metabolism. So a healthy, balanced diet, 3 meal diet is something which is advisable. Diets which are rich in phytoestrogens like soya beans or tofu or edamame, these something would be helpful for a woman to also get natural sources of phytoestrogens. The other important thing is to consume supplements. Calcium is something which is very essential at the age of 40 onwards. The requirement of calcium is at least 1000 milligram every day. And when you have to think about it as a diet thing, it requires a lot of additional milk or nuts or the green leafy vegetables. So you have to explain the patient regarding the same. Exercise is something which I make it a point that I talk to them about the exercises. What I usually tell them that try to do variety of exercises, which includes your metabolism, which includes your flexibility, or which includes your strength training. So either a swimming, running, walking, or cycling is something which will keep the metabolism better and it will protect the heart. Basic yoga or stretching, which can be advised, which will maintain the flexibility and reduce the joint aches and pains. And strength training, which is must for all the long bows because that reduces the progression of osteoporosis. And find out whatever triggers are there. Just for example, if you have hot flashes, find out what triggers it. If you have some mood changes, find out what triggers them. And then you can work on those things individually. Vasomotor symptoms are something which can deal with all the hot flashes and the other changes that can happen. So first thing is to try to avoid all the triggers which are possible. If there's some sweating which is happening or there's a feeling of hot flash, avoid beverages or hot coffee, avoid spicy food, and the temperature should be cooler compared to a hot air. Wear comfortable clothing which is very airy and keeps you comfortable. We have the evidence that a fast-paced respiration and a deep breathing helps to alleviate hot flashes. So this can be advice for the patient. Whereas the effective treatment for it is always estrogen, but then you can consider other modes of the lifestyle changes which can be done. One of the important thing is whenever you're giving estrogen, if there is a uterus which is present, there's no hysterectomy status, always try to balance it with progesterone so that you avoid estrogen overdose to that uterus to reduce the risk of endometrial cancers. If there's a hysterectomy which has been done, then you can just give plain estrogen for such patients. Perimenopause, menopause, likewise. Low dose estrogen can be in the form of pill or patch, which can be given depending upon whatever formulation you have around you. I usually prefer the conjugated estrogen 0.625. That's the one that we have, and that is itself sufficient. At times, even oral contraceptive pills can be enough, and they also provide minimal estrogen doses, which can be helpful for the patient. Apart from this, cognitive behavior therapy, wherein you talk to the patient, ask the patient to meet a psychotherapist, and work on these patterns can also be helpful. Similarly, a mind body technique where meditation and a holistic approach is also helpful for certain patients. Irregular bleeding can be a difficult part. One thing is always whenever you have irregular bleeding around this point, rule out a pregnancy because of the cycles which are irregular and nobody knows about the contraceptive thing. But these bleeding can be easily suppressed or easily managed by birth control pills. One of my favorite things to manage this irregular bleeding around this period is a Mirena. That's the levonorgestrel IUCD. It not just controls the bleeding pattern, it just reduces the bleeding, whereas the hormones are being maintained, which are naturally produced, and the patient gradually moves towards the menopause, and it's locally acting. So I do not have to worry about endometrial cancers, breast cancer, or ovarian cancer, which can be associated with oral doses. Once you're advising oral contraceptive pills, which are also beneficial, you have to understand that you have to weigh the risk benefit. At this age, there are higher chances of blood pressure and obesity. So you need to be careful along with that. There shouldn't be a family history of breast cancer, and the patient should not be smoking. The benefit for this is you not just get the hormonal regulation, but you also get a contraceptive benefit along with the pills. And this will also manage the hormonal up and down, which can happen around perimenopause. Therefore, a pill also can be beneficial at times. Severe hot flashes can be treated with a lot of medication that are available these days. You have venlafaxine, which is available, or Prozac, which is one of the commonly used drugs, and you have gabapentin. That is one of my go-to drugs. So gabapentin is something which we can use 300 milligrams twice or thrice a day to reduce the severity of hot flashes. Vitamin E is also said to be protective or gives certain benefits. So whatever works from your end, you can be advising that. Most of the times, most of the medications can have side effects because they are certainly affecting the SSRIs or they are used for blood pressure drug. So therefore, you have to use with control. And certain SSRIs can also interfere with metabolism of tamoxifen in women who are using it for a breast cancer risk. So we have to be careful regarding the metabolism of drugs at that point. Vaginal dryness, again, one of the commonest reasons the patient might present to you with. It's depending upon what you need to manage, you'll think about it. If it's something which is vaginal dryness and the time which happens is only during sex, she can be advised lubricants, which are water-based or oil-based lubricants, or she can be advised moisturizers, which can be used occasionally when the things are required. Though the final aim of treatment and the best treatment would be vaginal estrogens, which can be used to reduce vaginal dryness. Hormonal treatment has to be always under supervision and ruling out all the other contraindications. Though systemic absorption of vaginal estrogen is very less, but then there are still studies that can be leading to systemic absorption. So you have to be careful when contraindications are present. In general, what I also advise to everyone, this is something which every woman or every lady who comes around perimenopause gets an advice from me. Regular gynec checkups after 40. Start talking about perimenopause. Talk about the pap smear if she's not getting it done, and do a vaginal checkup. If the patient has something which is urinary complaint, then you explain her the Kegels exercises, which will be beneficial, which reduces the risk or the progression of SUIs. Mammogram is something which is must because the risk of breast cancer increases now with age. As per the guidelines, after 40, mammogram begins. From 40 to 50, it can be done once every 2 years. After 50, it's every year. A regular self breast examination is mandatory. So the woman will do a breast examination after her period bleeding is over, if the cycles are more or less regular. If the cycles become irregular, then she'll do a breast examination on herself on the first of every month. Ultrasound is something which is again vis-a-vis along with mammogram. So she'll do it once when she does the mammogram, the ultrasound will follow along with it. There we check for the lining of the uterus and to rule out any polyps or fibroids and ruling out any ovarian cyst or ovarian pathology which can be present in ultrasound. A bone density is advised to rule out any osteopenia or osteoporosis so that we can manage and reduce the progression to osteoporosis if there is evidence of osteopenia. Blood sugars, because I have to reduce the risk of her becoming diabetic. Cholesterol evaluation so that we don't let her become hyper cholesterolemic state. And in general, also talking about the hypertension risk that can happen along with this thing. Supplements usually recommend a calcium. 500 milligram itself would be sufficient because we expect the remaining 1000 of that 1000 remaining thing to come from the diet. Vitamin D to improve the absorption of calcium, and a multivitamin which includes magnesium, chromium, zinc. All these things should be beneficial regarding her external issues that she can come or present with complaints. And exercise, like I discussed with y'all, it has to be something which has to be targeted for her age. She'll do something for her metabolism, something for her muscles and ligaments, and something for the bones. When you go around like this, just drawing a chart, all my patients usually have this chart where we discuss about it, so that she can also go back and remember that these were the discussions which has happened. I just put an arrow and say when or the frequency when she needs to do it next or what she needs to do it so that she remembers, yes, these were the discussions that I had, and then she puts it as a part of a reminder or adds it to her lifestyle if it's something which is needed to do with diet or exercise. So key points to take home messages as we call it. Perimenopause is around the time of menopause when the ovaries gradually stop working. It's a natural process that can lead to physical and emotional symptoms. Most of the times you do not need any treatment, but if treatment is required, they can be recommended and this helps to lessen the symptoms. And the treatments might include hormones, antidepressant, and lifestyle changes, depending upon what you need to manage for the patient. And in general, advise a holistic approach so that the patient is better as a whole and you're not just treating the symptom for the patient. Thank you so much.
Thank you so much, sir, for your wonderful presentation. We do have some questions from our audience if you'd like to take that up. Yeah. So, sir, the first question is, what are the key clinical indicators that help differentiate perimenopause symptoms from other reproductive health issue?
So there's a lot of emotional changes that happen along with the cycle irregularities. And majorly what I'm looking about is cycle irregularities which can happen in the reproductive age group, can be because of PCO, can be because of stress which happens. And in this, you have a lot of emotional changes that you need to tackle also. And like we discussed, one of the blood investigation that you can ask for is FSH and E2, which itself will be pointing. One important history that you need to take is always ask for the mother's menopause or an elder sister's menopause. Usually the woman will also reach menopause around the same time. And that, if you can consider that perimenopause happens roughly around 5 to 10 years before her reaching menopause, then you know that yes, this is something which you're tackling with menopause, perimenopausal symptoms, and that will be helping you to explain it her better to her, and also for you to decide what line of treatment that you should be applying for her.
Thank you, sir. The next question from our audience is, how does perimenopause influence cardiovascular health and what prevention measures can be implemented?
So, one of the things that we discussed is because of perimenopause, there's a change in the lipid metabolism that happens in. Also, there's a change in the carbohydrate metabolism. So we see a lot of women when we do a checkup for them, the blood LDL levels start falling down, whereas the LDL level starts increasing and the LDL level starts going down. Along with that, you have sugar imbalance that happens in. So HbA1c, blood sugars and lipids are one of my standard investigation thing that I ask for them. So what this leads to is higher risk of diabetes and higher risk of LDL leading to hypercholesterolemia, which can be again leading to atherosclerosis. And because of all the mood changes and the weight issues that start happening in, their lifestyle is suddenly now sedentary. They also land up with higher risk of getting blood pressure. So when you add this thing as a whole, there's obesity, there's hypertension, there's diabetes, and there's cholesterol imbalance. All these things, when you take it together, obviously this will all lead to cardiovascular issues that can happen for this patient. Now that we have to think about how do we reduce it. So lifestyle changes again forms my baseline. You control the diet with the sugars and the cholesterol. If required, you can start on some the cholesterol reducing agents. If diabetic, then you can work on it. Make sure that she's checking her blood pressure and those things are controlled. And estrogen is said to be, when you think about MHT, the menopausal hormone therapy, and HRT, the hormone replacement therapy, whichever way you call it, estrogen is known to have cardioprotective effects also when it started before 60 in women who don't have any comorbidities or contraindication, but you have to be very careful when you're starting estrogen. And this itself shows that estrogen was one of the major reasons why the woman was protected during her reproductive age group when it compared with men. So in general, it's like a cycle, estrogen reducing, affecting the entire metabolism, leading to cardiovascular diseases. So you have to maintain a proper lifestyle so the metabolisms are corrected, which can be either by medication, which can be either by lifestyle changes so as to cut off alcohol, smoking, improve the lifestyle, walking, exercise, and all these things, and medications if required, and eventually the heart is protected.
Thank you so much, sir. The last question from our audience is, what strategies do you employ to involve patient in shared decision making regarding their perimenopausal healthcare?
So the best strategy is to make them understand that this is something which you're going through. The major issue that happens is not many are aware about it or they are hesitant to talk about it. So my thing is always I begin the conversation before she can come up with the complaint. I always say that, see, you're perimenopausal. You might have these issues or you might present with these complaints which are completely natural for your age, and it's not something abnormal in you, and it's not something that is making you going crazy. Once you say this much, she just feels a little more relaxed. The lady will start explaining or opening up more. So then you can target individual issues which can be important from her perspective. Also, once you start enumerating things that can happen to her, she herself has made a mental note. So once things start happening for her, she'll definitely come back to you with all these things, and then you can manage it individually. Don't try to treat everything at once because you yourself would be confusing with everything. Try to tackle one issue at a time. If there's something which is related to leg cramping, you can manage that part once. If there's something which is related to irregular cycles, manage that part first. And always see it on a broader scale. So never just manage these things. Always ask for a bone density. Always ask for the mammogram. Always do a pap smear test. So all these things are to be done. And one trick thing is, if you can, always talk in front of the husband or one of the family members because they are the support system. As doctors, I might just be interacting with her for maybe 15 minutes or half an hour during my consultation period, but then she's going through it every day, and the emotional changes or the mood changes or the lifestyle changes or whatever complaints that happen, and she'll be reflecting it on her family members, on her husband, the kids. So if you talk to one of the family members who will understand that, yes, these are the changes that can happen, and that member will act as a support system, might explain it to everyone and make her more stronger so that she can talk about these things at home, at workplace, and probably make the environment around her better around the topic of perimenopause.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding today's session, any last remark from you, sir?
Start talking about perimenopause because this is something which is not usually understood. We still have this term which is not many doctors are also aware about it. So once you understand the terms yourself, once you read about it more, you can actually understand that most of the symptoms or most of the signs that the patient can present to you with OPD can be just solved by just talking to them or understanding them. And don't ignore certain signs or symptoms that the patient might actually present with, which she might be going through. And once you point out all these things, once you mention all these things down, start treating them wisely and look again, what I always say, look at a broader picture, look it as a holistic approach, and then I guess your patient would be much better managed. Thank you.
Thank you so much, sir, for joining us today.